Let's focus on head injuries in this lecture. Now, the causes of head injuries could be many. Maybe the patient is an elderly patient, got up in the middle of the night to go to the restroom and slipped or tripped, hit their head on the floor. Maybe the patient was assaulted, or maybe the patient had some type of motor vehicle accident and again suffered some head trauma. The thing that we need to focus on with head injuries is brain swelling. Remember that the brain is protected by the skull, and because of that, swelling must be limited, because if brain swelling occurs to a significant amount or to a large amount, this swelling will decrease the amount of circulation to the brain. If we have decreased circulation to the brain due to the swelling, then we have decreased oxygen supply to the brain, which can lead to death of the brain or death of brain tissue or an infarction. So let's focus on some clinical manifestations that you must know for the Nclex exam. Again, this will depend on what trauma was sustained. And I'm going to clump in intracranial pressure and things like skull fractures together because you may have similar clinical manifestations. So number one, headaches and vomiting, typically without nausea. Sometimes there may be nausea, sometimes there might not be nausea, but in either case, most likely most patients complain of vomiting or suffer from vomiting or dizziness or seizures. Again, the headache, the vomiting, that has to do, or that is due to the brain swelling. Remember that the skull is going to keep the brain kind of trapped, protected. As the brain begins to swell, it's going to begin to compress on the skull. That will result in headache and vomiting. Also dizziness, and again, if the brain swells to a large amount, we worry about seizures. Now, depending on what part of the brain was affected, whether the patient is having some type of cerebral bleed due to, again, brain swelling due to trauma, patient may suffer from memory loss. I've had a couple of instances where patients came in through the ER, they suffered a MVA, or a couple of instances where patients were assaulted, hit in the head very, very hard. Those patients came in vomiting. And the other thing that I found in common with these patients is that they were extremely irritable and restless. They wouldn't hold still. There was a change in their level of consciousness or a change in their mental status. They weren't acting like they usually would. Family members would say, you know, this isn't typical of them. They're not acting like they usually do. Again, this is attributed to the brain swelling. Number three, dilated pupils or pinpoint pupils. So you're going to assess pupils. Are they reactive to light? Maybe they're slow, or maybe there is no reaction to light stimuli. So this is big here again, dilated or pinpoint pupils. Number four, Cheyne-Stokes respirations or abnormal breathing. We're going to get to that here in a little bit more detail. Number five, decerebrate or decorticate positioning, or maybe the patient is completely flaccid, meaning limp. There is actually no muscle tone. Now, if the patient is suffering from a decerebrate position, this is indicative of serious injury. Number six, Cushing's triad or Cushing reflex. This is a medical emergency. Now, if you remember, and maybe you don't remember Cushing's triad, number one, systolic hypertension with widening pulse pressure. Number two, bradycardia with full bounding pulse. Now, this is very interesting because you have a slow heart rate, yet you still have a full bounding pulse. Number 3, irregular respirations, or again, Cheyne-Stokes respirations. Again, this is most likely an indication of brainstem compression or herniation, and again, that is due to the brain swelling. Now, if this occurs, most likely what will result is respiratory arrest. So again, we always want to look at our respirations, and we want to make sure that they are not irregular. If they're becoming irregular, we need to report that to the physician immediately, because again, one thing that we worry about is the herniation or the compression of the brainstem, which will result in respiratory arrest. Number 7, again, depending on the trauma. We talked about how head injuries may be resulted due to, or may be caused by an assault, or may be the result of a fall, some type of trauma. If that is the case, maybe the patient was a young individual that was on their motorcycle, crashed, hit their head on the floor, and they suffered some type of skull fracture. If that's the case, we want to check to see if there is any cerebrospinal fluid leaking. We want to look for what's known as battle sign. So we're going to look for post-auricular ecchymosis or periorbital ecchymosis. Now I'm giving you the fancy terminology because most likely on the Nclex exam it will give you that terminology, so I have to prepare you for that. But what essentially this means is a bruising behind the ear and raccoon eyes. Now that typically indicates a skull fracture. Now if there is a skull fracture present or suspected, you also want to look for what's known as the halo sign, which would indicate cerebrospinal fluid leaking, either through the nose or through the ears. Now, if you get this halo sign, you also want to test for glucose. Remember, the brain is always needing energy, and it gets its energy source from glucose. Therefore, if we were to test cerebrospinal fluid, we would find that it has a large amount of glucose. So that is why you would test for glucose in CSF. Make sure you know that for the Nclex exam. Now, if there is a skull fracture, if there is leaking of CSF, that makes it very, very likely for that patient to suffer from infection or meningitis. If that's the case, you need to watch out for knuckle rigidity. Now, we talked about head injuries, either due to falls, assault, trauma, but it can also be caused by, for example, a mass present, some type of tumor, and the result is the same. We have to worry about brain swelling or increased intracranial pressure, which again is a result of the brain swelling. So let's consider that as we focus on our diagnostic studies. Now, if it is due to some type of trauma, MVA, assault, we want to make sure that we also look at the spine, make sure there's no fracture present. So patient may get x-rays of the C-spine or cervical spine, or they may also get a CT done. If we are worried about brain injury or brain trauma, most likely what will be done is something known as a head CT, and it will be done without contrast. We also want to look at our ABGs. Like I mentioned before, we worry about Cheyne-Stokes or abnormal breathing patterns, irregular respirations. We worry about the brainstem being compressed or herniating. If that's the case, respiratory arrest may result. So we want to make sure we pay attention to our ABGs, make sure that the patient is getting inadequate oxygen supply to the brain. Also, we want to know what caused the trauma if the patient did suffer something like an MVA. So you may do something like an alcohol level. You still want to look at your CBC, BUN. Now, medications. Now again, we need to focus on cerebral or brain swelling or cerebral edema, because again, we always worry about that. Again, if the brain begins to swell, that's going to decrease the amount of circulation that the brain gets, which again decreases the amount of oxygen that the brain gets. So let's focus on that. Number one, corticosteroids. Something like Decadron. Again, I always tell you that you need to focus on the things that make a certain pathology unique. Well, Decadron is very unique to cerebral edema. Again, corticosteroids, remember that these are used for decreasing inflammation. So Decadron or methylprednisolone, solumedrol, these are given to decrease cerebral edema. Now, a couple of things that you must know is that if you're going to be giving these medications, Decadron or methylprednisolone, you must find out if the patient is suffering from hypertension, diabetes, or renal failure. Number two, something like mannitol, a diuretic, may also be given. Again, this is in hopes of decreasing cerebral edema. Now, in most cases, when patients come in through the ER, a urinary catheter is inserted, especially if you're going to be giving a diuretic. You can also give something like pentobarbital, and this is given in hopes of decreasing intracranial pressure. Number four, Dilantin. This may be given to prevent seizures. Now, what are some interventions that you will do for your patient? Number one, I already mentioned this, you will assess their respiratory status. Again, this is key because if we have no respiration, we have no oxygen supply to the brain, and the brain can die or infarct. So number one thing is you assess their respiratory status. Put them on continuous pulse ox, again checking ABGs, checking respiratory rate, assessing the depth of their respiration. Number two, you assess for changes in their level of consciousness. So you will look at or assess the Glasgow Coma Scale. Now the highest score, the score that you want to get, is a score of 15. Make sure you know that for the Nclex exam. If you have a 15, a score of 15, perfectly fine patient, nothing wrong with them. If, however, they have a score of 8 or less, this is typically indicative of a coma. So what we are assessing in the GCS is essentially brain function. So we're looking at the patient. Are they able to open their eyes? Are they responding to our voice, to our commands? Is there proper motor response to stimuli? So again, make sure you know that for the Nclex exam. Number three, we want to monitor intracranial pressure, ICP. And this is typically done for patients with a GCS score of less or equal to 8. So if it is less or equal to 8, then again we want to begin monitoring their intracranial pressure. Now the gold standard for monitoring intracranial pressure, is something known as the ventricle ventriculostomy. Now this is simply a catheter placed in the lateral ventricle in the brain. Now this ventriculostomy is also going to allow for the removal of cerebrospinal fluid. So if the physician sees that this, getting a little ahead of myself here, normal intracranial pressure is between 10 to 15. So if the intracranial pressure, let's say, starts going up 16, 17, 18, and the patient has a ventriculostomy in place, well then cerebrospinal fluid may be removed. Again, the goal is to have an intracranial pressure between 10 and 15. Now, what are some things that would increase intracranial pressure? Make sure you know these for the Nclex exam. Number one, hypercarbia. Again, we talked about how the respiratory system may be affected. They may have irregular breathing patterns. The brainstem might be affected, which again would cause respiratory failure. Therefore, we always want to assess again our ABGs, paying close attention to our CO2 levels. Again, we want to prevent hypercarbia, or you want to prevent high levels of CO2 because this can increase intracranial pressure. Now, we must keep a patent airway. Patients will most likely be on ventilation. So we want to make sure we maintain our O2 sats greater than 92%. So again, we're always assessing their O2 levels. Again, we want to maintain a normal intracranial pressure between 10 and 15. Number two, on our things that can increase intracranial pressure, tracheal or endotracheal suctioning. That can lead to an increase in intracranial pressure. Coughing, blowing their nose. If you were to flex or extend their neck or hips, this may also increase intracranial pressure. So the positioning of our patient is very important. We want to maintain the head of the bed at about 30 degrees. We want to maintain the body in a midline or neutral position. This is very important for you to remember for the Nclex exam. Again, we want to maintain the head of the bed at about a 30-degree angle. Now this is if they have a ventriculostomy in place. Remember, there are other ways of controlling intracranial pressure. I'm only giving you one in this scenario. Other things that can increase intracranial pressure are the Valsalva maneuver, or when the patient is having a BM. Number four on our interventions, we want to maintain seizure precautions. Again, if there is a rise in our intracranial pressure, if there is a rise in our cerebral edema, this makes it likely for this patient to suffer from seizures. So you want to maintain seizure precautions. You want to keep our side rails up and padded at all times. We want to monitor our fluid and the electrolyte levels. In a previous lecture, we talked about how hyponatremia may cause cerebral edema. Well, that is why we need to monitor our electrolyte levels. We definitely do not want to cause hyponatremia because that's only going to increase cerebral edema. It's going to increase intracranial pressure, which is what we do not want. We want to monitor our fluid levels because if we have fluid overload, that's going to lead to hypertension. And again, that will result in increased intracranial pressure. So again, we always want to monitor our fluid and electrolyte levels. Number six, even though the patient may be in a coma, may not be fully alert, you always explain your procedures to the patient because the last thing to go is our hearing. So again, you always want to explain your procedures to your patient.